Abdul Shukur is going to present on intestinal obstruction, and my presentation is being supervised by Dr. Patrick. So this is the outline of my presentation. We'll start with classification of intestinal obstruction, the pathophysiology, the approach to intestinal obstruction, the complications, and also the management of intestinal obstruction. So first and foremost, basically we can divide intestinal obstruction, either it is the small bowel obstruction or large bowel obstruction. And both small bowel obstruction and large bowel obstruction can be further divided into either it is a dynamic obstruction or adynamic obstruction. And further, from dynamic obstruction, we can further divide either it is a complete or partial obstruction, or either it is strangulated or simple obstruction. We'll go to each type of intestinal obstruction afterwards. So, how do we classify based on the clinical finding, either it is a small bowel obstruction or large bowel obstruction? So, before we go further, we have to bear in mind that there are 4 cardinal signs of intestinal obstruction, which are abdominal pain, abdominal distension, vomiting, and also constipation. So, mainly we can classify small bowel obstruction and large bowel obstruction based on these signs. Okay, for both bowel obstruction, the abdominal pain is usually colicky. However, in small bowel obstruction, the pain is usually around the periumbilical area. Large bowel obstruction, the pain is usually at around the lower abdomen. And it comes earlier in small bowel obstruction, and the vomiters usually cause bowel obstruction, and might be later progress to become frequent. So in small bowel obstruction, the constipation comes later as compared to large bowel obstruction, and for abdominal distension, it is less severe in small bowel obstruction as compared to large bowel obstruction. Okay, so we know that from both small bowel and large bowel obstruction, we can further divide into basically dynamic and type of bowel obstruction. Peristalsis is still working against a mechanical obstruction, while in adynamic obstruction, it is also called as functional obstruction, and there is no mechanical obstruction in this type of obstruction, and peristalsis is also absent or inadequate in this type of obstruction. The examples of adynamic obstruction is paralytic ileus. Okay, so here are some of the causes of dynamic IO. We can further divide either it is intraluminal, intramural, or extramural. So in intraluminal, there is fecal impaction, foreign bodies, bezoars, and also gallstone. While intramural includes stricture, malignancy, intersusception, and also volvulus. For extramural, the common causes are bands or adhesions and also hernia. For adynamic or functional bowel obstruction, the 2 main causes are paralytic and pseudo-obstruction. In paralytic ileus, there is failure of transmission of peristaltic waves secondary to neuromuscular failure, which will end of obstruction symptoms. The causes of paralytic ileus can include post-operative infection, reflexes, and also metabolic causes. Okay, so in differentiating dynamic and adynamic bowel obstruction, we can look at these parameters. For instance, in bowel sound, those who have dynamic bowel obstruction may have high-pitch active bowel sounds, while in adynamic bowel obstruction, it is hypoactive or absent. And peritoneal sign may be present in those with dynamic bowel obstruction but absent in adynamic. And based on the investigation, the abdominal X-ray, you can see dilatation proximal to the obstruction in dynamic obstruction, while generalized dilatation is present in adynamic obstruction. And then we can further divide either it is complete IO or partial IO. So basically, those who have complete intestinal obstruction, they might have all 4 cardinal signs, and the patient was unable to pass motion and also flatters. Sometimes we also call this as obstipation. And in partial IO, the symptoms is milder and patient usually still able to pass flatters. Okay, so this is a table of the common causes of small bowel obstruction and large bowel obstruction, and also a pie chart showing the causes of intestinal obstruction. So we take a look at the causes of small bowel obstruction first. We can see that the first one is bowel adhesion, the second one is hernia, macrodiverticulum, strictures, and also malignant tumors. So based on literatures, it is said that in developing countries, hernia is higher in developing countries, while in developed countries, usually the bowel adhesion is the most common cause of small bowel obstruction. But for large bowel obstruction, the common causes are malignant tumors, diverticulitis, volvulus, adhesion, and also stricture. Okay, so on to the pathophysiology of bowel obstruction. So in bowel obstruction, the bowel proximal to the obstruction will dilate. Bowel below the obstruction or distal to the obstruction will exhibit normal peristalsis and hence becomes empty and later collapse. If it is not relieved, the bowel will continue to the acidity and paralysis of the bowel. Other factors actually causing the dilatation. The two main factors causing the dilatation is first, gas, which due to significant overgrowth of both aerobic and anaerobic organisms in the bowel, or fluid, which is made up by various digestive juices such as gastric juice and pancreatic juice. So the question now arises, how does dehydration occur in patient with intestinal obstruction? Okay, so basically dehydration can occur in those with intestinal obstruction due to third space fluid loss. Okay, other than the four main or cardinal signs of intestinal obstruction, other clinical features of intestinal obstruction also include, these are the four main cardinal signs of intestinal obstruction, which are abdominal pain, which is usually colicky, abdominal distension, vomiting, and also absolute constipation. Apart from these cardinal signs, patient might also have dehydration, hypokalemia due to excessive vomiting, pyrexia, abdominal tenderness, and high-pitched bowel sounds. Okay, so this is also another subtopic of bowel obstruction, which is closed-loop intestinal obstruction. So when does closed-loop intestinal obstruction occurs? It usually occurs when the bowel is obstructed at both the proximal and distal point of the obstruction, as opposed to the normal bowel obstruction in which the distension is usually at the proximal part. In this type of intestinal obstruction, the distension is principally confined to the closed loop and the distension proximal to the obstructed segment is not typically marked. And a classic form of this type of obstruction is seen in the presence of a malignant stricture of the colon with a competent ileocecal valve. This diagram will further show regarding the closed loop bowel obstruction. So we can see point A is the point proximal to the obstruction, and point C is the point distal to the obstruction. So in normal intestinal obstruction, in other type of intestinal obstruction, the dilatation will occur at point A, but in closed loop bowel obstruction, the dilatation is prominent at point B. Okay, as pressure builds within the closed loop, blood supply is quickly compromised and patients with closed loop obstruction may progress rapidly to bowel edema and also perforation. Okay. Now we move on to strangulation. So strangulation occurs when the blood supply is compromised and the patient is more ill than you would expect. So the features of strangulation includes constant pain, tenderness, rebound tenderness, and also shock. So we can say that these four are actually warning signs. So let's say during our night shift, we have a patient who just come up from ED, and this patient was actually referred for incarcerated hernia. So during our night shift, these are actually the 4 main things that we have to watch out for this patient, because we don't want this patient to go into strangulation. Okay, here I also provided the summary box with causes of strangulation. So the causes of strangulation can be due to direct pressure on the bowel wall, which is caused by hernial orifices or adhesions. It can also be interrupted mesenteric blood flow due to volvulus or intersection, and also can be due to increased intraluminal pressure due to closed loop obstruction. Okay, so now how are we going to approach a patient in which we suspect intestinal obstruction? So first, we go from the history taking. The history taking must consist of the cardinal symptoms of intestinal obstruction and the causes of intestinal obstruction if we were thinking of intestinal obstruction. So let's say if we're thinking about malignancy, we need to ask regarding altered bowel habit and also any constitutional symptoms. And as hernia and adhesion is one of the commonest cause of small bowel obstruction, we also need to take that into our consideration. So we also need to ask the patient regarding any risk factors of hernia, and for family history, we need to ask regarding the history of malignancy in the family. And also, past medical or surgical history is very important. And then after we get the full history, we need to proceed with physical examination. So in general, what we are looking at in this patient is the hydration status to see if the patient is dehydrated or still having fair hydration, and also general well-being of the patient, which might lead us to the diagnosis. Okay, and then we move to the per abdomen examination. We have to see if there is any tenderness, palpable mass, the scar, and also do not forget to check for the hernial orifices, as hernia is one of the commonest cause of intestinal obstruction. And we also cannot leave the digital rectal examination, in which if there is malignancy, we might find mass or rectal bleeding. Then after that, we'll proceed with investigation. We'll divide the investigation into blood investigation and also imaging. So for blood investigation, we should take FBC, in which we might see polycythemia in dehydrated patient, leukocytosis, and from the RP, we can see increase in urea, serum potassium, and also LDH, which might also indicate that the patient is in the state of AKI. Okay, for plain abdominal X-ray, the main findings include dilated bowel loops and with or without the presence of fluid levels. So during interpreting the plain abdominal X-ray, we need to use the 3-6-9 rule, in which small bowel should be less than 3 cm, the large bowel should be less than 6 cm, and the cecum should be less than 9 cm. And also, we can also do erect chest radiograph to screen for complicating perforation. But the positive predictive value for erect chest radiograph, we have to bear in mind that it is only around 50%. So we still cannot rule out any perforation if we cannot see any pneumoperitoneum from the chest radiograph. And we can also proceed with CT scan. This is the imaging modality of choice if a colonic obstruction is clinically suspected, and CECT can help distinguish between partial and complete obstruction, ileus, and also small bowel obstruction. So these are the examples of abdominal X-ray in those with intestinal obstruction. In the first one, we can see that there is multiple air fluid levels denoting a small bowel obstruction. And the second abdominal X-ray, we can see that there is very dilated bowel. Okay, this is also another pathognomonic finding for sigmoid volvulus, which can also be the cause of intestinal obstruction. This signs is also called as coffee bean signs. And this is also another example of large bowel dilatation seen in abdominal X-ray with pneumoperitoneum. Okay. As for CT scan, we can see a distinct transition point where bowel caliber changes from normal to abnormal, and the dilated bowel loops proximal to the transition point. The bowel might also be collapsed or normal caliber bowel distal to the transitional point, and the surrounding mesenteric fat stranding indicating there is inflammation. So this is an example of a CT scan finding in which there is dilated contrast-filled loops of bowel on the patient's left, which is shown by the yellow arrows, with the compressed distal small bowel on the patient's right, shown by the red arrows. And the cause of obstruction in this case is incarcerated umbilical hernia, which is shown by the green arrow. And we can also see there is a proximally dilated bowel entering the hernia and the compressed bowel exiting the hernia. So the principle of management in intestinal obstruction is, first, we need to hydrate the patient with fluid and electrolyte replacement. And then we have to decompress the bowel. Usually we'll insert NG tube, and also we'll try to relieve the obstruction. And if the conservative management is still cannot improve the patient's condition, we'll proceed with surgical treatment. So when do we decide for surgical intervention? It is actually dependent on the clinical feature. And the indications for early surgical intervention includes, first, obstructed external hernia, clinical features suggestive of intestinal strangulation, and also obstruction in a virgin abdomen. Okay. In conditions where obstruction is likely to be secondary of adhesions, conservative management may be continued for up to 72 hours in the hope of spontaneous resolution. So this is a chart showing regarding how do we approach patient with small bowel obstruction. So first, we need to do our initial evaluation, which include history taking, physical examination, and then taking the blood for investigation. From our initial evaluation, if we see that the cause of bowel obstruction is due to adhesion, we have to think either the patient needs emergency surgery. So how do we say the patients actually need emergency surgery? If we see there is signs of strangulation, bowel ischemia, and peritonitis. So these three are the signs of signs requiring emergency surgery in this kind of patient. So if the patients have any one of these signs, yes, we'll proceed the patient with surgical exploration. But then, if the patient does not develop any one of these three signs, and then we'll proceed with imaging, and we'll still proceed with non-operative trial, in which we'll keep the patient NBM, start on IV fluid, and also try to decompress the bowel with nasogastric tube. Okay. And then after that, we'll reassess again the patient, and we'll decide either the patient still need operative management or the bowel obstruction has actually resolved. Okay, so if the patient have failure of non-operative treatment in which the obstruction still persists for more than 72 hours, or there is high output drainage volume, which is more than 500 ml on the third day or after the 72 hours, and the patient starts to develop peritonitis or ischemia, in which the patient will have exacerbation of the pain, CRP will be increased, white blood cell will also increase, and there is free intraperitoneal fluid of more than 500 cc, we'll proceed with surgical exploration for that kind of patient. Okay, so this flowchart basically summarizes the management of patient with intestinal obstruction from the first approach and from the first encounter until we manage the patient. Okay, so this is a case study of a 50-year-old man which present to our ED. This man has actually come with underlying gastritis and presented with worsening colicky, abdominal pain for 1 week duration, abdominal distension for the same duration, and also associated with reduced oral intake. So at this point of time, what should we be thinking of? Does anyone would like to try? So in this patient, we should be worried about intestinal obstruction, peritonitis, and perforated viscous. So we need to get further history for this patient regarding the cardinal signs and also about other risk factors which might be preceding to this presentation. And then we proceed with examination. On examination, the patient is actually alert, pink, not septic looking. His hydration is actually quite fair, and the vital signs is within normal range, in which the BP is normotensive, 109/68. The heart rate is 77 beats per minute with temperature of 36.6. On per abdomen, noted that it is grossly distended with generalized tenderness and also guarding, and it is most tender at right iliac fossa with sluggish bowel sound, and cough impulse is negative. So, per rectal examination done showed there is anterectum. And then we proceed with investigation. We take the blood for FBC and also RP and also VBG in this patient. So the HB shows that the patient is actually anemic with HB of 8.1. Total white cell is raised 15.87 and the platelet is also raised. For the RP, it is fairly normal with urea of 2.6, creatinine 77, sodium 134, potassium 3.7, and chloride of 98. The VBG also shows metabolic acidosis. Okay, and then we proceed with abdominal X-ray for this patient. So on this abdominal X-ray, we can see that there is dilated bowel, in which when we measure, it is 7.7 centimeter. So using the 369 rules, it is more than 6 centimeter for large bowel, and hence it is a sign of intestinal dilated bowel, and it is a sign of intestinal obstruction. The patient later underwent CT abdomen, in which it shows there is long segment splenic fracture of obstructive lesion, most likely malignant in nature, and there is also multiple liver lesions, which is most likely metastasis, and lung findings are suggestive of active lung infection. So initial management was done for this patient, in which we keep the patient NBM, we start him on IV drip, and also we put in rice tube free flow and 4-hourly aspirate. And then after reviewing the CT scan, the patient was proceeded with op, and intraoperatively we noted there is splenic fracture tumor 5.5 centimeter with ascites of 300 cc, hemoserous in color, and there is closed loop obstruction with dilated cecum till proximal to tumor. And the patient actually underwent laparotomy extended right hemicolectomy. And we changed our diagnosis. The post-op diagnosis was intestinal obstruction secondary to splenic fracture tumor. So I think that's all for my presentation, and here are my references.